Hello again. I'm Dr. James Amos, staff psychiatrist at University Hospitals in Iowa City, and this is another geezer video. This is a dirty dozen on somatoform disorders, and I've made a number of these already, and this will consist, as usual, of a dozen slides, and there will be a full presentation available on my blog site, the Practical Psychosomaticist, at jajsamos.wordpress.com. The somatoform disorders cover a wide array of medically unexplained physical symptoms which are burdensome to patients and puzzling to many physicians. I'd like to just read to you from the introduction to the somatoform chapter in the book edited by myself and Dr. Robert G. Robinson, Psychosomatic Medicine, an Introduction to Consultation Liaison Psychiatry. And there I once again plugged my book. At any rate, in Chapter 8, Dr. Kathy Kaufman writes, as far as background, medically unexplained symptoms have been estimated at about 10%, and there's a wide range of prevalence figures. Estimates are that 27% of patients present to outpatient clinics with unexplained conditions. These conditions are seen frequently by various medical specialties, including chronic fatigue syndrome, fibromyalgia, multiple chemical sensitivity, non-cardiac chest pain, and non-epileptiform seizures. The recognition and management of somatoform disorders is very important, and there needs to be close collaboration between psychiatrists and primary care physician and other medical specialists. Once again, I'm going to keep track of the slides here in front of me so as to stay on track, and you can see the full presentation once again on my blog site, the Practical Psychosomaticist. So starting with slide 3, the somatoform disorders, or medically unexplained physical symptoms, are marked by symptoms that are burdensome and painful for patients, and a puzzle for many doctors who try to find it and fix it, which is what most doctors are trained to do in medical school. They can encompass 25 to 75% of primary care visits due to somatization. The prevalence in general practice settings can be about 16%. Hospital costs are 6 times higher than controls. Ambulatory costs are 14 times higher than controls. And the estimated annual cost could be as much as $256 billion. The psychiatric comorbidity tends to be high, with many patients suffering from depression, anxiety, and other disorders. The consequences of medically unexplained physical symptoms include an impaired physician-patient relationship, which is critical to healing. The consensus is that there's a dose-response sort of relationship between the number of medically unexplained physical complaints and the level of frustration that physicians typically feel and express. So when there's only one symptom, for example, 6% of physicians find them difficult, on up to 6 to 9 symptoms in which 23% of physicians find them difficult and frustrating. Patient dissatisfaction is high in situations like this, and depression and anxiety occur at higher rates than in the general population, and there is poor quality of life and high healthcare utilization. Medically unexplained physical symptoms are seen by multiple specialty providers, not just internal medicine and family medicine. They're seen in internal medicine with complaints such as chronic fatigue and fibromyalgia. That doesn't mean that I'm calling these syndromes only psychiatric. That's a form of either-or thinking that I try to discourage. In gynecology, they tend to be seen with complaints such as chronic pelvic pain, and in digestive disease centers with irritable bowel syndrome. Those are just some examples. Somatization disorder, which is sort of the flagship and best example of medically unexplained physical symptoms occurring as a syndrome that's been identified for many decades, includes multiple complaints across many organ systems, usually starting before the age of 30. And its prevalence is estimated at between 0.2 to 2% in American women, And this type of disorder tends to cut across cultural and national boundaries and international boundaries. It has many similarities to personality disorders in that it's chronic and tends to cause a lot of interpersonal and occupational impairment. The DSM-5 proposes to rename this as a complex somatic symptom disorder, for those of you who are following the DSM-5 progress. The next slide, slide 5, is the DSM-4 diagnostic criteria for somatization disorder. And as I said, it's a history of many physical complaints, usually beginning before the age of 30, and that occur over a period of several years and result in treatment being sought or significant impairment in all spheres of life. And by definition, they include 4 pain symptoms, 2 gastrointestinal symptoms, 1 sexual symptom, and 1 pseudo-neurological symptom, such as non-epileptiform seizures. They're not explained fully by a medical condition, and the complaints and impairment are viewed to be excessive in terms of the objective findings, which are usually few. And it's not intentionally produced or feigned, such as would occur with factitious disorder and malingering, which I'll mention briefly here, but about which I've also developed a Dirty Dozen presentation. Body dysmorphic disorder and conversion disorders will also probably be renamed or reclassified in the DSM-5. Body dysmorphic disorder tends to be viewed nowadays more as belonging in the obsessive compulsive spectrum. And it causes profound psychosocial dysfunction, and it's comorbid with depression and anxiety disorders, as well as social phobia and obsessive compulsive disorder. It has a 17% suicide rate, which is alarmingly high, and they are often seen in cosmetic surgery departments. Antidepressants such as selective serotonin reuptake inhibitors may be helpful, and psychotherapy such as cognitive behavioral psychotherapy is also effective. Conversion disorder is a very, at times, mysterious somatoform disorder, which may be moved to the dissociative disorder category because it has many characteristics common with dissociative syndromes. The DSM-5 may rename this as functional neurologic disorder, which will do very little to change the way that we manage it. You usually avoid confronting people with this diagnosis, and there's a very practical way of dealing with it, which is to simply suggest, in many cases, that the symptoms will go away, that there's no dangerous medical condition or neurological condition associated with them. And in most patients, that will be sufficient. However, in a significant minority of them, there will be a recurrent pattern of medically or neurologically unexplained symptoms, usually thought to be in connection with a psychological or social stressor. Pseudoseizures tend to respond less well than motor disorders to treatment, and tends to have a somewhat poorer prognosis. Functional MRI studies show very interesting limbic or frontal lobe suppression of activity in motor and somatosensory cortices, and you should look at the Feinstein reference in my list of references at the end. Hypochondriasis and pain disorder are next on slide 7. Hypochondriasis is a preoccupation with bodily symptoms or function, and a persistent belief that these symptoms are related to some identifiable disease, even though there is no evidence to support that idea. It's usually unshakable, and one should endeavor not to try to reassure patients with this type of health-related anxiety. And in fact, in the DSM-5, there is a proposal to call this illness-anxiety disorder. It may respond to the selective serotonin reuptake inhibitor antidepressants, and it may also respond to cognitive behavioral therapy. Pain disorder is marked by a major focus with pain as the singular complaint. And it may be marked by dramatic display of the pain complaints, drug misuse or drug dependence, doctor shopping, disuse and degeneration, dependency, demoralization, and disability seeking, which used to be formally known as the disease of the Ds. Special cases of somatoform presentations of psychiatric illness include presenting somatization of major depressive disorder and anxiety disorders such as panic disorder, because they do at times look very physical. Vegetative symptoms that one can see with depressive disorder is loss of appetite and a variety of physical complaints such as abdominal pain, which typically tend to resolve with adequate treatment of the underlying psychiatric disorder. Other special cases include factitious disorder and malingering. Malingering is actually an accusation, not a psychiatric disorder. In factitious disorder, I've mentioned already in another Dirty Dozen, and there's a presentation about that that you can find on my blog site. The goals of collaborative care in identifying and managing somatoform disorder include the primary care physician trying to adopt a conservative approach and avoiding invasive procedures, medications with the potential for addiction and toxicity, and referral to other specialists, while paying more attention to objective signs and objective changes rather than subjective complaints. It includes often adopting a habit of watchful waiting. The role of the psychiatrist is to help manage comorbid psychiatric problems that are readily amenable to standard treatments such as major depressive disorders, anxiety disorders, and substance use disorders. And the idea is to coordinate with primary care and to endeavor to limit doctor shopping as much as possible. The somatoform disorder's approach to the patient may to some degree depend on whether the somatizer is facultative, meaning amenable in many ways to discuss the role of psychosocial factors, or chronic, and these patients often are less amenable, at least initially, to psychiatric methods of management. It's very important to validate the patient's suffering, which is respectful and supportive, and one may spend a fair amount of time in the validation phase developing a therapeutic alliance with somebody who has been through many, many doctors who have somehow managed to give the patient the idea that all of the physical problems that he or she complains of are in his head or her head. It's very much better to acknowledge that the pain that the patient feels is in his or her body and work from there. Assessment phase must include attention to the physical complaints themselves, and one may include a physical examination. The reattribution phase, which may occur much later in the relationship between doctor and patient, may involve trying to hook up psychological or social problems with the physical problems, but not always in a one-to-one or cause and effect relationship. It's not always necessarily true that because someone has a psychological problem or a social challenge, that necessarily leads in a one-to-one fashion to a physical problem. And it can be invalidating to suggest that to any patient. The management phase can be much more important with people who may be resistant to change, at least in the initial phases, and would consist of the usual conservative management techniques already mentioned. Slide 11 are the selected references, and slide 12 is sort of a tribute slide to a former mentor of mine, Dr. Russell Noyes, who developed the Health Attitude Survey, a rating scale that was validated many years ago in screening people who may have somatoform disorders. It's also available in a long and short form, and it seems to be acceptable to patients. Well, this is a very brief overview of a large, complicated problem. Somatoform disorders don't exist just in people's heads. They're physical problems. The patients aren't lying about them, and they are indeed suffering. And it takes a lot of trust and working together amongst psychiatrists, primary care physicians, and patients to achieve healing. Once again, I'm Dr. James Amos, and this presentation, if you're seeing it on YouTube, will be available on my blog site, The Practical Psychosomaticist. Have a good day.